Oh, there we go. All right, so chapter 14, looking at our corrective strategies for the thoracic spine and shoulder here. So what we're talking about today, we are looking at these major sections, looking at our T-spine, making sure we can flex and extend, laterally flex and rotate. Mostly that is going to be looking at our thoracic vertebrae if we're looking in there. Then we're also going to get into our cervical vertebrae as well, motions of, what our head can do. We're going to look at our ball and socket joint that is our shoulder joint proper, which is going to be how the humerus sits in that glenoid. And then we'll take a look at our shoulder girdle as well, which is going to be that collarbone and scapula interacting with that thoracic spine section. So definitely some larger pieces of anatomy here, a lot of moving parts, a lot can go wrong. But for the most part, I find it to be, you can see like we kind of jump right into the program making here. A little simpler in a lot of ways. There's not quite as, a lot of it works together in conjunction. So like when you see dysfunction, it's like, well, there's this dysfunction and it's this list. It's pretty black and white, which is what's nice about it. Looking here at some of the anatomy, we can see our shoulder girdle. We're mostly paying attention. We're not so much looking at the humerus here. We'll get into that in just a little bit. But when we're talking about like the shoulder girdle, we're talking about the anatomic structures of the scapula and how it interacts with our clavicle. So shoulder girdle a little bit different than like our shoulder joint. So we're seeing here, if you look at this like sort of front section, we've got our clavicle coming across. That's your collarbone. And this right here, this little like sternoclavicular joint right there. This is the only like bone on bone contact that you have that holds your both of your arms like entirely onto your body, which is kind of fun. That's my fun little factoid for you. There's not a ton of like bone on bone connection here. It really is just a lot of like soft tissue. Like, if you consider like your scapulothoracic joint, right, where like the scapula is sort of interacting in some ways with the ribs there and the spinal column, that's all muscle that holds that together. There's no ligaments or anything like you would normally see in a lot of like joints. So we call that a false joint because it doesn't have any of our normal anatomical structures. This joint right here, that's the bone-on-bone contact that you get. So not a lot of stuff holding your arms onto your body, um, which is kind of fun. But as we sort of look at this, this should be able to move just a little bit superiorly and inferiorly. It doesn't have a ton of range of movement. You can see, like, if I try to take my collarbone up as high as possible, that's about it. Comes back to here, and then there is just a little bit of extra depression, maybe at the very most 5 degrees, where it can sort of move downward, but still not very much. What that kind of tells us, and this is just a general guide map, I think you guys have heard me say this before, but generally when you see something that is very immobile, like in terms of, you know, bony structure, right? Like you think about like our three types of joints that we've got, right? The ones that we spend kind of all of our time talking about are our fully movable joints, our synovial joints, right? We spend most of our time talking about that. And they're 80% of the joints in your body. Like they are by far the king, the star of the show when it comes to talking about like joints and stuff. But you do also have like semi-movable joints, each of these individual vertebrae are not fully movable, not synovial. They are semi-movable joints. And that's great because we have our entire central, well, not our entire, but a giant portion of our central nervous system running through this spinal column here, right? And we want it to be protected. So, as a general rule of thumb, what you'll often hear is that with decreased mobility comes increased stability. The less something moves, the more protected it is, right? So, luckily, these semi-movable joints here don't really do a lot of movement, and that's a good thing. That allows us to, keep this nice and safe. Same thing with like the sutures of your skull, which are fully like fibrous. They're really not even joints at this point. They're kind of fused together. You know, um, to kind of, they're non-movable joints, right? Well, yeah, there's our brain. This thing that we definitely want to keep as protected as possible. So again, with decreased mobility, it's about as unmobile as it gets, comes very much increased stability. So then, that's a good way to kind of pivot us. Oops, sorry. Pivot us into talking about, like, again, the collarbone here doesn't do a ton of movement, but it is a relatively stable joint. You don't hear about too many clavicular dislocations, although it can happen. It seems horrifying, or you can break your clavicle. But for the most part, this is a pretty stable area. So it is kind of holding everything on, but it does need to all kind of move as one unit. That's one of the very interesting things. That's probably the most important point that we want to make, is that, like, when you do move your collarbone, your scapula is going to move with it. These two things, your shoulder girdle, really does kind of move as one solid unit there, right? And so your collarbone, your clavicle comes across here and sort of connects to this joint right here. Now, this number 2, that is your AC joint, or your acromioclavicular joint, which, like I said, this was my interview when I, interviewed for Sochi. And when you are nervous, saying acromioclavicular joint a million times over and over again, quite the tongue tire. I don't know if I've ever had so much trouble saying that word. Very AC joint right here. That is where that's going to meet. So that's giving us a good connection here. So as you sort of look at it, you can see from the back here, it's the sort of like comes along this ridge here. This is what we refer to as the spine of the scapula. And it kind of hooks forward like this. Like it points out like that, and then boop, it just kind of hooks at the end. And that is what's going to allow your collarbone to come across and get a good piece of contact there. So, again, they are very much connected, and we know that anytime you move one bone, it's going to move any of the bones it's connected to, right? Again, that interdependence model that NASM likes to talk about. But this is a very good example of, like, that is creating that stability. Now, right next door, we do have our shoulder joint, or you can sometimes say the glenohumeral joint, right? And the reason we call it that is because, like, this little cavity right here, actually, let's go back a slide, and then we can really see that cavity, right? This little, like, dented shape here, it is just like, like what we saw sort of in the picture here. It is kind of like a golf ball on a tee. Like, you can roll that golf ball around in all directions while still keeping contact with, like, this little tiny indentation that the tee is sort of holding the golf ball onto. And so, this big gap right in here, we call that our glenoid cavity, right? And that glenoid cavity is what allows the head of your humerus to sit in there. Now, here's again, let's kind of go back to this, this same thing we just said about the whole, with increased mobility comes decreased stability, right? Well, this is a ball and socket joint. It has a ton of, contact and surface area and stuff, but it has a full range of movement through that. There's a lot of space in this joint. So with all of that increased mobility, it is a relatively unstable joint, which is why you hear shoulder dislocations as such a common problem. And so you can see here, we're covering this whole thing with lots and lots and lots and lots of connective tissue. And all that connective tissue is going to hopefully give us the stability that we need. But because it's soft tissue, it still gives us the mobility that we need. So we do have, like, bone-on-bone contact there, but we need to have lots of space available, and we need to have lots of connective tissue to hopefully hold it all in place. And so there's a lot of dysfunction that can kind of come along with that. So I'm going to kind of jump forward to the end of the PowerPoint here, just because that's where they like to keep their common issues here. So there are a few issues that come along with, again, the more mobility you have, also, the likelihood that something could go wrong is kind of increased. And so we'll sometimes see rotator cuff tendinopathy, or rotator cuff tendonitis, where, it could be that a rotator cuff muscle where it is inserting is actually rubbing on the bone, experiencing some kind of friction. That friction causes inflammation. That inflammation causes aches and pains. We could also get shoulder impingement, which is very much hard tissue, preventing soft tissue from being able to move. You look at shoulder impingement, it looks something kind of like this. Um, so you can see there is normally a goodly amount of space between the bones here. And then this is the supraspinatus muscle, runs over top and inserts onto the head of the humerus there. So supraspinatus is in charge of helping with this motion right here. Now, obviously, you might be thinking, like I thought that was my deltoid, I'm doing lateral raises so I can like work on my deltoid and stuff. Sure, it is your deltoid, but that supraspinatus muscle is also in charge of making sure that that moves correctly. And and on top of that, there is a little bursa there, which is like this little fluid-filled sac filled with, this kind of egg white fluid. And your bursa basically are there to reduce friction as these two like bony marks have this like little muscle running through it. It's there to prevent that friction and rubbing sensation from happening. But if you spend a lot of your time in altered posture, you spend a lot of time in altered positions, well, you can end up tightening up the muscles that surround the joint, and you can end up pinching the joint and closing off some of that space. So you can get bursitis, which I don't think is mentioned. No. So bursitis is where you can actually pop or rupture your bursa, and then that little fluid-filled sac leaks out, and now it's no longer there as, the sort of packing peanuts that you would have to reduce friction. Bursa literally are kind of like the little air packs that Amazon puts in your packages to like, prevent things from rattling around too much. So that's there to reduce that friction. But without that reduction, we're gonna see like that rubbing sensation. So bursitis is a very common thing, or you can get shoulder impingement, like we see here, where it's rubbing because there's limited space between the two bones there. Impingement, literally, just if you want to say it in your head, your clients will probably never know, so you can say impingement. um, or we could see like an actual dislocation. You can see a dislocation or a subluxation of your shoulder joint, which is horrifying, um, and very, very, very painful. Sometimes, I mean, you'll hear stories like of people who like dislocate their shoulder and somehow, like, I don't know how they do it, but just in some miracle, somehow did not actually tear any of the ligaments or connective tissue on the way out. And
My
then,
ex,
what's
he
that?
did that. My ex, he was bodybuilder, huge
Uh,
dude, 6'6", 290 pounds. He dislocated his shoulder playing basketball.
uh-huh.
And it took 4 doctors to put his shoulder back into place.
Sure.
And he didn't break anything, didn't tear,
Wow.
no tendons broken, no nothing, no
Yeah.
nothing. All he had was swelling and bruising from the
Sure.
from the dislocation. But yeah, no, he didn't. He literally, and the doctor said the same thing. Like, do you know how lucky you are that nothing tore? Like
That's wild. Yeah.
everything's intact. He's like, you just have bruising and swelling. Like, yeah, my ex literally.
I have a picture that I keep on my phone. My buddy Josh at Ultimate landed on my friend Patrick's foot after they were like, going up for a pass or something. I think Josh was going up for it. Patrick was trying to block it. And Josh just landed on Patrick's foot. And so twisted his own ankle when he landed and just completely separated his ankle from his tibia. Like, I have the picture on my phone, you can see the condyles through his skin, like of his tibia, and his foot's just hanging there. And he, just one of the worst dislocations I've ever seen in real life in my life. He went to the doctor and like he had one little like your classic lateral ankle sprain, like one little tiny ligament had like a very minor tear in it, but the rest of it was totally fine. And they just kind of like like so, and that's I'm sure with you say your boyfriend or your ex or um it's the same thing. It is crazy to watch. I don't know if anybody in here has ever seen, you see it in movies all the time where like they'll go thunk, they'll like put someone's shoulder back in place, or they'll in Lethal Weapon, I think it's two, if anybody's seen that, he like slams it into the wall and it puts his shoulder back in place. That's not how that works. You can
Not even
technically,
close. not
Yeah, you
even
could have like an
like
anterior subflexion, and then maybe that would work. I doubt
putting
it.
a shoulder back into its socket is the most morbidly uncomfortable thing you will
Yeah,
ever do in your
yeah.
career as an
It's like
anything.
this
Like,
weird, and then like thunk, like
yeah,
yeah,
see, and my ex was so big, that's why it took four people
I'm
because
sure.
his muscles kept pulling him off of alignment every time they tried to raise his arms
Yeah,
up. So
that's their job.
literally, yeah, it was like two male doctors and two female doctors trying to like push his fucking bone back into the
Yeah,
socket. Like
yeah, I
it
believe
is
it.
so disturbing. It's disturbing.
Question. Is that something you would have to do like when they're under sedation, or would you have to do it like normally?
I think they do it while you're conscious, because they kind of
Uh,
need you to move a little bit. They need to like they need to like prop yourself onto your side and stuff. Because it is like it's essentially this weird overhead movement where they pull down and over, and then they kind of come over your head like this. So I imagine they need you awake. I don't know. I that's not quite my area. I don't the procedure itself is over my head. I've only seen it once because I just happened to be in the room, you know, at urgent care. This is my favorite silly story. I might have told you guys this. I was there when Betty White dislocated her shoulder. It's a different Betty White, but still Betty White. Not the Betty White. My Betty White.
I was gonna say, now that lady is dead. Don't be don't we don't look. Listen, the
She was
black
still
community
alive when this
loves Betty
happened,
White.
though.
Okay,
They were
the
both
black
running
community
around at
loves
the same
Betty
time.
White. Not too much.
Yeah. Oh, it was awful, man. She just fell. Just it was at the resort, and I was the trainer on staff at the time, and she got so excited. She was trying to run around the counter to show one of the front desk girls this video on her phone or something, and we had like those concrete like Costco style floors, like the kind of shiny concrete, and she just slipped, and it was like, ugh, it was such a bummer. Needless to say, Shantis, it was a lot easier to put Betty's shoulder back in alignment than your 6'6" guy. um, so yeah. So that's so and you can get there's different versions of dislocations and subplexions. You'll see like the one that's sort of the most common is you'll see a lot of times like this kind of thing, where you can see like afterwards there's if the connective tissue did tear and is very severe, sometimes they'll even need to you'll kind of be stuck with like something like this. Or if you break your collarbone, you'll sometimes see lumps like this, um, but yeah, the most common one is basically it falls out of alignment inferiorly like this. It kind of just like drops straight down. There we go. There's the other ones. Sometimes you'll also see like an anterior dislocation God, I don't know how you would even get a posterior dislocation. That seems really painful. But yeah, they basically just roll on it and pull on it until it kind of slides back into alignment. And they got a whole protocol for it, I'm sure. Um, this is where I had somebody the other day I was at a party and we were talking and they were like, you know, certain doctors are way more similar to mechanics than they are to anything else. Like they're just mechanics for, the human machine. Like it's like boom, Ugh. Um so other issues that you'll sometimes run into, rotator cuff strains. So your rotator cuff obviously is a big group of muscles, but you can strain any of those muscles the same way that you would anything else that's basically a pulled muscle. Um, so impingements obviously are a thing, but you can see, I mean, like all of this connective tissue, ends. And so like, yeah, you can pull that. Absolutely. Um, it can be really severe if you end up like tearing something, that is often going to require surgery. Some people can get away without it, you know. Some people can tear a muscle and, if it's a minor tear, maybe it'll heal up on their own. Or sometimes people will get like a full-blown rotator cuff tear, and just like entirely detach that darn thing, and they'll just kind of live through it. You'll sometimes hear people doing that. Um, crazy to me, but hey. Biceps tendinopathy. Now this one, you get a biceps tendinitis basically. Um, Now, this one's a little bit less of a bicep problem and will feel like a shoulder problem. Okay. So you're going to get pain here in what will feel like shoulder pain. And a lot of times it can actually be from very tight bicep muscles. A lot of people in like the service industry get this a lot. You'll see individuals who are like carrying trays like this can be a very common injury for them. And you're like, well, yeah, I mean, they got a little bit of elbow flexion there, but it's not like they're doing bicep curls, right? They're mostly holding it on their shoulder. Like they're using a lot of shoulder strength. It's like, yes, but you got to consider like this is a pretty awkward position to be into as for long isometric durations. So you'll see this sometimes. Here. Um, you'll see as this kind of comes up, it does have to run over the head of that humerus. So again, biceps, two sets of fibers here, right? You've got your short head, which is running on the medial side, and you've got your long head running here on the lateral side. And so like this long head has to travel a further distance. Let's get a slightly better picture here. That one works. So you can kind of see here, right? If you consider this outside bicep muscle has to run all the way up and over into this, whereas this one is inserting right onto that coracoid process there. So, both of your biceps are inserting here at the shoulder joint and girdle, but in different places. Like this one is on the humerus itself. This one's on the clavicle, which is why you can actually target your biceps ever so slightly differently when you are training them by rolling your shoulders back or doing positions where you actually let your arms drop into a position like this. That is putting your biceps brachia into a stretch so that now you have to rely entirely on a different muscle like your brachialis, which is down here, by the way. So this can rub, this can get inflamed. Again, that's going to come from awkward postures, tight muscles. Again, if you have rounded shoulders, these are going to be in like a shortened position. That's going to pinch that, and that's going to cause like a rubbing sensation. Then you can also just get general shoulder instabilities. You can get blanket tears or slap tears. Man, I thought I had a slap tear earlier this year. I thought I got a slap tear at my St. Patrick's tournament. Lucky enough not to. But blanket tears. So I can get a picture of both these at the same time. I kind of doubt it. Am I lucky? Oh, yeah, kind of. So you'll see little tears like this. So again, we're looking at the lateral view here of our shoulder. And so sometimes you'll get like a blanket tear down here, which is just basically where you'll get this like bad instability. Basically what's going to happen now is your humerus doesn't have a full-blown cavity here because this glenoid, right, is very similar to how your meniscus works, right? So if you kind of consider it's, we call it a labrum, right? Which we have in our hips as well, but like it's similar to the meniscus. And we talked about this just a couple of days ago, but you think about like, how your meniscus works. Like if this is the top of your tibia, right? You have one elephant ear. That's what I think it looks like on this side. And you have another one that's kind of C-shaped on this side, right? And like what that does is if you looked at a lateral view of that, like so now here's the kind of top of your tibia there, right? It's really thick on this side and then it gets thinner down towards the middle and then thick on the outside and thinner down towards the middle. So what that does is that means like as your femur kind of comes down, has these condyles here, it's way less likely to roll out over this edge or roll out over this edge. So the labrum is a pretty darn similar thing, except that if this was the cavity, it's kind of more like this. It's sort of an intercentral section. And thank you. An outer section like this, and it's more of like a donut shape or a red blood cell shape that kind of creates, and again, it would be if you were to look at this from the side, it would be sort of give us a little circle there, thicker towards the outsides, right? I guess you wouldn't be able to see it. It would be, I guess, kind of that. But yeah, it's thicker on the outsides and thinner on it. And that what that does, that deepens the cavity, which makes the bone less likely to roll out of alignment or, dislocate. So looks kind of like this. And so that's our labrum. We have that in the hip as well. And there's, by the way, there's that biceps tendon, right? Eventually all of this kind of runs into and becomes like, again, rolls up and over the humerus there, up and over the humerus there, and then comes in. So it's in that little glenoid fossa right there, And so if you tear it at the bottom, we call that a Blankert tear or a Blankert lesion sometimes. Or you'll sometimes get like a slap tear, which is usually on the top, well, which is the top side. That's, oh Lord, what does slap stand for? Superior labral. Remind me what slap tear means. I'm forgetting my acronyms. It's not good. Superior labrum anterior to posterior. That's what it is. So it goes from front to back. Okay. So yeah, that's a pretty common one. There's a couple different versions of slap tears and Blankert tears. So physical therapists will know a bunch of different tests to tell you basically what's going on. They can look for, there's one called the clunk test, where basically they move you through this range of movement, and if you hear like a thunk, like that's a sign that it's that fossa is dented on one side. So as your bone's sort of rolling through it, it literally like falls into a hole for a second, then gets back into smooth territory, and then falls for a second. So there's a bunch of them. There's a bunch of different shoulder tests. Actually, I don't know all of them. It's, again, that's physical therapy territory. But yeah, that is your shoulder instability, right? Small tears that can happen in any of that connective tissue. And then lastly, these should totally not be together. You've got osteoarthritis, which is kind of similar to shoulder instability, except that that is a wear down of the connective tissue gradually. So it's just compromised connective tissue rather than having what we would consider to be like a full-blown tear, just kind of slowly breaking down. Time and years of on the life treadmill, and so that causes just general shoulder instability. And then there's frozen shoulder, which is a pain in the butt. Frozen shoulder, guys, if you ever get a client who has it, you can continue to work out. I don't know. There is some shaky evidence out there saying that it could possibly improve frozen shoulder, but frozen shoulder is a really, really weird condition where basically all of that connective tissue gets so inflamed and so tight and hardens, and it just kind of gets stuck. And then your client, it hurts in the sense that like it's very claustrophobic feeling from what I've been told. It hurts in the sense that there's like a little bit of a dull ache. It's not like a super like painful tear or anything like that. It's not that kind of injury. But your client will just lose the ability to like put their arm over it. They'll like lose it like to fully move their shoulder. It is super frustrating as the fitness professional working with it because it comes out of nowhere. You can kind of work on it. It might have some improvements, addressing their posture and things like that. But there's really not treatment for frozen. Sometimes people go get cortisone shots, and that really doesn't do much. And then one day it just goes away. It is like a demon that just shows up and hangs out with you for a couple weeks and then disappears forever. It is the dumbest. I've only had I've worked with it like 3 times. All 3 times I've had people be like, "It was amazing. You got it to go," da, da, da. And I'm like, "No, I didn't." Like, it just kind of goes away on its own. It's a really, really weird condition. That we don't know as much about as we would like to. But yeah, if you ever want to look up and read about frozen shoulder syndrome, it is a really weird one. But it does, I will say, it is, I just saw that gave me an idea. Yeah, adhesive capsulitis. But yeah, it's basically it just kind of freezes up because it gets like so inflamed, and then eventually that inflammation kind of goes. I would say frozen shoulder is more similar to like really bad plantar fasciitis. Like sometimes people get plantar fasciitis. They haven't even been doing a ton of physical activity. You look at the you'll work on it, you'll do all this stuff, and then one day there's like it's better, and it's like I don't know why, like you didn't do anything special. Um, but yeah, really annoying, really weird condition. Um, what is the recovery time? Yeah, I was gonna say it can take up to 6 months, 18 to 24 months. That's crazy. Oh my God, 18 to 24 months. Can you imagine dealing with that for 2 years, just like straight? So, um, yeah, adhesive capsulitis. uh, uh, so, those are some of our conditions that can happen in the shoulder joint. Like I said, it's a relatively large list, but like it's all going to come from, again, the big things we're looking for: rounded shoulders, forward head posture, and elevated shoulders. Those are our big three today. So let's go ahead and yeah, we can see some of our muscles here. Again, we've got our supraspinatus muscle, and then I love this. We get a good list of our concentric actions. You guys have seen this every day so far, but like supraspinatus, it's helping with that abduction. Subscapularis, that's an internal rotator. Infraspinatus, that's an external rotator. That is a big one that we're oftentimes trying to work on. Teres major is an internal rotator and an adductor slightly. And it even does a little bit of shoulder extension ever so slightly. So again, 3 actions. Guess what? This is the muscle. This is the muscle that oftentimes gets overactive. So we need to find ways to sort of deactivate that so that we can work on these better internal rotators like the subscapularis there. So one of the ways to do that, again, if this is in charge of adduction, well, guess what? All we have to do is abduct ever so slightly. This is why, guys, if you've ever seen, let's see here, cable internal rotations. So you'll see, I mean, you will see this, right? Like the first couple images we see, that one's actually not bad. It's a drawing though. So you see this guy here doing this, right? And he's just kind of doing it by himself. Elbow is kind of tucked in this specific position versus like something like that's also a drawing. Good Lord. Can we? It's not as common to see cable internal rotation. Mostly people need to do cable external rotations. Yeah, I'm not even seeing what I want. How frustrating. This guy? Nope. All right, so if you're doing cable internal rotations, here's the tip. You should do it with a small rolled up towel tucked under your arm. And that ever so slight abduction will put your teres major into a stretched position, thereby deactivating it, keeping it from taking over if you are trying to work on those internal rotations. So teres major is the overactive shoulder rounding bad, not officially part of the rotator cuff, but like internal rotator muscle that we want to not strengthen. We want you to be able to do shoulder internal rotation. We want you to do it correctly using the right agonist muscles instead of these overactive synergists. So all we have to do is roll up a towel, get it under the arm there, and abduct ever so slightly, and do your internal rotations with a little gap in between them. So that's going to make a big difference. Teres minor, external rotation, and then we got our deltoids. Like anterior goes front, medial or lateral deltoid goes to the side, and posterior deltoid actually mostly in charge of extension, by the way. But yes, it does do a little bit of external rotation as well. But you see people all the time, like this drives me a little crazy. You see people all the time like trying to work on their posterior deltoids, and they'll do like reverse flies, right? And they're like trying to work on there. And I'm like, look, I love reverse flies, but like if your goal is to fill this in, you'd actually get a little bit more out of it going at a downward angle because it is better at extension than anything. And you get more out of it by doing cable external rotations, which we love. And then it would also be very good for all those synergist muscles. So not a huge fan of the bro version of a reverse fly personally. Then here's all of these big old, like, agonist muscles that we're more familiar with here. So pectoralis major and minor. Now, I will say this, your pec major and your pec minor do not work the way a lot of people think they do. I know you guys know this, but like your pec major inserts onto your humerus, so it moves your arm. Your pec minor inserts onto your scapula, so it moves your shoulder girdle. Those are different. So you can even see pec major. It does a little bit of flexion, and weirdly it's not listed here, but your pecs also can do a little bit of extension. Weirdly, these are total opposites of one another, but it's because your top fibers, your superior fibers of your pec major, assist with raising the arm up overhead. The bottom fibers assist with pushing the arm back. But that's very unfamous. That's not its main job. What it should be known for is horizontal adduction and a little bit of internal rotation. So it does swing in this way, and it's very much responsible for that flying motion. Pectoralis minor, scapular protraction like we're doing here, but it also does this forward translation of your thoracic wall. What the heck is that? That's basically saying it anteriorly dumps your scapula forward. So it doesn't only just bring it forward like this, it kind of rounds it forward and dumps it like that. Because you got to think of it as like, if I had just like a long cylinder like this, right? And I had, an eye hook attached to it here, and I attached like a rope, and pulled this down, right? Well, what's going to happen? This is going to tilt. It's going to tumble over like this, even if I have this on wheels, right? Let's say I put this on wheels. And I'm trying to move this weird thing, so I'm trying to roll this, this way. This is a horrible way to transport this thing. All I'm going to do is pull it right off that back wheel, and this whole thing is just going to dump forward and fall. So if I had a second eye hook, though, down here and a second rope attached to it over here, and I pull both of these simultaneously, well, now the whole thing is going to protract forward. So that's literally what's kind of going on in your scapula. Your pectoralis minor is only grabbing the top part of that scapula, so it dumps it forward like this. Your serratus, which is under here under the pectorals, it grabs the entire scapula. So it's in charge of it's the difference between protracting your shoulders forward and protracting your shoulders forward. You know what I mean? We don't want that anterior dumping. That is much harder on our posture. Hopefully my weird on-the-fly wheel analogy helped. So that's the pec minor. Lats, working with the pecs in some ways, antagonistic in other ways, but your latissimus dorsi comes up from the backside under the armpit there, and it inserts onto the humerus. It kind of comes around and wraps like this. It grabs onto the front side. So when it pulls, it's pulling down and back around my back. So that causes internal shoulder rotation. Look at how many internal shoulder rotator muscles we've got. And now we go back to our poor rotator cuff over here. And it's like your external rotators are your infraspinatus and your teres minor, which the teres minor is smaller than the teres major. So it's working against the teres major. It's working against your lats, your pecs. So many muscles internally rotate. It's no wonder we walk around like this all day. And then these damn things. So yeah, so that is very much an internal rotator. It's also an adductor. That's its main job. Your lats pull the shoulder blades down, right? It's an adduction. It also does shoulder extension. So one of the things we've talked about, I think, in previous classes, but remembering our anatomy, right? Like a pull-up is very much a lat exercise because it does shoulder adduction. But a chin-up does shoulder extension. It is also very much a lat exercise. But I will say you're getting a little bit more assistance from your biceps when you do a chin-up and a little bit less when you're doing a pull-up. But both of them work your lats. The distribution's a little bit different, but they're both very, very good exercises. And you kind of want to practice if you're trying to build a balanced ability to pull both those. So a lat pull down this way, a lat pull down this way. Both those are very, very good for you. They're just slightly different ways to work the same muscle. Different sets of that fiber. This is where, like, if you're working with a bodybuilder, guys, like, you want to make sure you're balancing, kind of evenly getting everything out. Alternating between those two in your routines is a good way to change things up, keep things from getting stale, and, build different parts of the muscle. Then we got all these muscles that we got to strengthen. Our rhomboids, they are directly working against that pectoralis minor. This was a scapular protractor. This is a scapular retractor. Your middle trapezius, also a scapular retractor. Your lower trapezius, now it's not getting credit here, but it is also a little bit of a scapular retractor. So mid and lower traps, both good at pulling your shoulder blades back. But our and to be fair, even the upper trapezius does do a little bit of scapular retraction as well. But the thing that the upper trap also really likes to do is scapular elevation. Now that's directly antagonistic to scapular depression, which we get from the lower trapezius here. So these muscles synergistically work together for retraction, but are antagonistic in terms of elevation and depression. And most people have excessive scapular elevation. It's just kind of how we hold our tension as a species, We're driving and we're like, or, I mean, the example I always use is I just pull up pictures of Mad Daffy Duck. Like, just a perfect example. Here's a weird thing I will say. I love cartoons anyways. Like, I've never given up on just like watching cartoons. But like, it's a classic thing that we do. Like, one thing that cartoonists are really good at is they have to draw like a fictional character and convey emotion with like a drawing. There's certain things that, like, like bloodshot eyes, obviously, but like the elevated shoulder thing, the rounded shoulder thing, it instantly, exactly what emotional spectrum, this character is going through right now. I think cartoonists are very good at kind of recognizing human anatomy and like translating, posture to feelings. But yeah, like, it's a great example. I mean, like, we hold our tension like this when we are pissed. Like, when we're angry, that's how we do it. I mean, Yasmin, and you're having a rough day, you don't have to chime in. Feel free to just stay there and be sick. But like, I'm sure, you, like, after sneezing or coughing afterwards, like, if you're like me, you're holding all this tension. It's like, like, it's hard. Um, so we get that. And then, like, we have other things in our life, like our jobs and this and that. Like, you could be working, and like you start rounding and elevating up like this to kind of get up and over the keyboard and like bear down on your work, and it's like, great, now you have, you know, and again, this is getting a little, I don't want to get too hippy dippy here, but like, you talk about like how your posture is also, like, there's a built-in psychology to your posture. Your brain's thinking, like, you could just be working normally, right? But your brain's like, hey, that's my stressed out posture. Ah, I must be stressed out. Like, and then it makes stress hormones and you get tension headaches back here. So upper traps getting really tight, very, very common. Another one there, just in terms of that scapular elevation, is the levator scapulae. No surprise there. It's elevates the scapula. But it also, again, it's kind of similar to our little analogy here. Now I've almost got another rope, tied to something like this, pulling this way. And yeah, guess what? Again, if I didn't have this here, right, this would dump this forward. So your levator scapula is also kind of playing into that scapular dumping action along with the pec minor, causing that rounding to happen in our shoulders there. Meanwhile, your serratus is doing scapular protraction, but again, it's pulling, along this whole thing. It's actually kind of ridged on all of it. And so it pulls it nice and level, which we want. We want to be able to protract. We just don't want to overly protract. So there's some common force couples here. The scapula, the shoulder girdle, and the shoulder joint are always our go-to. They're always our go-to when it comes to like talking about like force couples, multiple muscles working around a joint. So you kind of consider this example here, right? Your serratus is in charge of like pulling this and protracting it around. Like if you're doing something like a pushing motion like this, you should be able to round your scapula around your rib cages. We need to do it. That's what's facilitating the movement. But your middle trapezius needs to give that some pull backwards like this. Lower trapezius needs to pull back like this. And what that's going to do is that's going to create that stability, right? Like you think about like when you are moving something or carrying something, right? Good example. Let me see. Let's just find a picture, you know, see a picture of somebody carrying a box, right? You'll often see like, sure, there's this version where it's like both hands just kind of underneath, but a lot of times you'll see these are all boxes that don't have anything in them. So many stock images of empty boxes. Come on now. There we go. You'll see this kind of thing. Like he has support under the box because yes, we are going against gravity. But then this one is pulling back, right? And it's like, if I'm trying to go, bring it over that way, right? Why would I have support pulling towards me this way? Well, that's bracing it into my body, which is then like isometrically giving me something to kind of push into. So because I have so much pressure coming, just squeezing into myself, the amount of weight that I have to lift from the bottom is massively reduced. So you'll see, oh, there's another one, right? You kind of see this kind of thing where we wrap it around to the other side. That's kind of how force couples work, by having like this stability coming from two different directions, not just directly the one thing that you're working on. So we need to have this like isometric stabilization coming from the traps. And because so many people have tight pectoralis muscles, which are antagonistic to the traps, again, protractors versus retractors, well, we end up inhibiting these muscles. And so now our upper back gets inhibited and weak, and we get this rounding action here. We don't have any of that stability. We have an altered force couple, and now we just start moving with bad posture. Rotator cuff, same problem, we start using the wrong muscle. Your rotator cuff here, we see the subscapularis. Now that's the one that's an internal rotator that we want to use, but the teres major along with the latissimus dorsi, which are massive, they start taking over and doing our internal rotation for us. Problem is those muscles actually round our shoulders forward rather than just give us, the internal rotation like this. We get it like this, this massive excessive movement there. And all these little tiny itty bitty rotator cuff muscles, your teres minor, your infraspinatus, and your supraspinatus. Supraspinatus not doing as much, but infraspinatus and teres minor, they're trying to work against those internal rotators. So they have a really hard time kind of keeping up. So again, do your external rotations, do your internal rotations with the cable machine, but you can keep your elbow tucked for your external rotations. You can also give it an ever so slight out. Those are two slight different variations of the same exercise. But when you're doing internal rotations, make sure little gap in there, guys. That way you can actually use your subscapularis rather than using the teres major whenever you're doing it. And then supraspinatus coming up and over top, that's more of an abductor than anything. That's there to help during, lateral raises and overhead presses and things like that. And then there's the pec minor and scapula, the malposition. Yeah, again, there's that anterior tilting. I call it scapular dumping. That's the term I, kind of worked around talking about. But, again, look at these fibers. There's your pec minor right there, right? You can even see, So this is one of the reasons why, I like to have the arm up and externally rotated and ever so slightly, abducted away from the body when I'm doing like a pec stretch. Like I don't dislike this version of a pec stretch here. It's good, but I especially more than like the one where it's up here just ever so slightly. That's going to give you just this kind of downward pull in the same direction as your pec minor. I find that it's a little bit better for you to have the capacity to like roll your shoulder blades down and back while you're stretching out that pec. You know, if you want the pec major all by itself, great, just do this one. Just straight arm, stretch it out. Nothing wrong with that. You know, you're doing horizontal abduction. It's the opposite of horizontal adduction. That's just totally a great way to stretch your pec major. But if you want that pec minor, you gotta roll that scapula back. Again, we'll get into that in a moment. So, a lot of shoulder stuff. Let's take ourselves over here really quick. So then with that lateral scoliosis, again, could be functional in nature, could be that like functionally you are shifting due to bad habits, or maybe due to your job or something where you're in the same position all the time. My mom is dealing with that right now. Then there is also the structural scoliosis, which is you're born with like a lateral or transverse twisting action of the spine there, right? So observations you're going to see, one shoulder blade being higher than other, looking at it and seeing one side is elevated while the other isn't, or one that is sort of anteriorly rotated more than the other. You can see this doesn't look too different right now, but if I look from the side, here you can see like this shoulder is retracted normally, and this one is protracted excessively. So sometimes you'll see a transverse sort of twisting action there. Uneven hips, same thing, one elevated, one depressed, or again, rotation of the spine there. One good way to tell, like to look for scoliosis is to, from the posterior view, look at the shoulder blades and the gap between the inner ridge of their spine. You can look at like the apex of the scapula, like the little point at the bottom, and just measure the distance from there to the spine and from there to the spine. If you see they're uneven, that can show sometimes that there's a lateral shifting or rounding. Then we'll also sometimes see kyphosis, or this upper rounded back, often associated with what we call upper cross syndrome. Rounded back, internally rotated shoulders, and usually a forward head posture as well. So that is going to come from different places of bad activation or bad alignment of the kinetic chain. So we are looking at, again, this sort of rock and a hard place here, where is it the cervical spine affecting the shoulder, which is affecting the hips, or is it the hips that is affecting the shoulder, which could be affecting the cervical spine, or is it just a shoulder dysfunction that is affecting both other directions? Yes. Again, like it really can kind of come from any of those things. But if we are looking at that rounded shoulders, right? Or if we're looking at that hyperkyphosis or that shoulder elevation, again, we are trying to find ways to restore length to the muscles, reduce the concentric pull of the muscles that cause rounding and excessive anterior pulling, and work on those muscles on the posterior chain that are going to likely pull us back into the correct alignment. So during the overhead squat, we're going to see arms falling forward. That is going to obviously be tight latissimus and pectoral muscles and weak upper back stabilizers in order to get those arms up overhead. Scapular elevation, levator scapula, sometimes sternocleidomastoid, but oftentimes upper trapezius and scalenes. Now, occasionally, there could just be dysfunction with lordosis of the low back. Sometimes we'll see that anterior pelvic tilt, and that can be a shoulder dysfunction. But again, that is that tight latissimus muscle. It does come down and have that thoracolumbar fascia, you know, kind of giving us a wedgie, if you think about it. And then scapular winging as well. Scapular winging is a little bit of its own thing. That is where you'll see somebody who is not effectively protracting. They are really exclusively using the pec minor to do their protraction rather than being able to like round across effectively. So a scapular winger, oftentimes it's pretty uneven. Oftentimes that'll be associated with often a scoliosis. So look at this version here. Yeah, no, this is probably a little closer than this one. But you can see either way, definitely scapular winging on both sides, you know. But I'm like, is that a scoliosis? Maybe a little bit. Another good way to tell is to look at the gaps under their arms. If you see a big gap on one side, that can be a sign. But yeah, sometimes you'll see scapular winging. It'll oftentimes be uneven. But it is where we have that excessive protraction, you know, and it's not protracting the way that it is supposed to be. So working on those upper back muscles, yeah, there's definitely a scoliosis right there. So yeah, it's common that these two things sort of run in the same circle. Or you could be like the kid from Stranger Things. um, let's see here. Collarbone. Here's an interesting one. You could also have, what is that called? Cleocraniodysplasia. Pretty uncommon here. But this is actually where you'll sometimes see, oftentimes they are missing certain teeth. They don't develop correctly, and then you will see like a lack of collarbones. It's kind of absolutely wild. What you'll see that people are kind of capable of doing with that, but fairly rare condition. It's actually one of my favorite things that they wrote into the show because he got cast without them really knowing that. And then they approached him later and they're like, "Can we write this into the show?" And he was like, "Yeah, bring awareness. People don't know about it." And he's like, "Whoop," you know. He's like, "Wow." um, so I kind of love that actually. But very different than that. Scapular winging is just, again, it's major scapular dumping. And so again, like some of the best stuff you can do, guys, is work on your serratus anterior. Again, that little muscle under the pectorals, the little like fillet muscles there that you'll see. And again, that's working on protraction specifically. So things like push-up pluses, or you can get a foam roller on a wall and push up like this. You can see how much movement my scapula is doing. And like, you can even see it kind of stick out there as I go into this position here. You know, I had to deal with a lot of scapular winging when I was younger. I was a lanky, skinny kid, you know. There's a lot of, it takes a lot of work to kind of get that to go away. Scapular elevation, winging, arms fall forward. Oh, and then shoulders elevating, again, on our pushing and pulling assessment, forward head posture. And then if somebody can't do an overhead press correctly, and you see this kind of thing here, where they push like that. Again, very much tight lats, weak external rotators, so weak rotator cuff, and altered posture. Same thing in the Davies test. So let's take a look really quick. I did want to address two other things. I wanted to look at the scapular winging, and I wanted to look at the asymmetric weight shift. So pause.